We have a real treat for you to close out the day today. We have Dr. Hayden Andrews, who's here from UT Southwestern, where he's an assistant professor of medicine, and he's a former MGH Brigham ID person. And he gave this talk to our group, and it was extremely popular. So this is, do I really need Meropenem, common ID, curbsides, everything you wanted to know about ID, but were afraid to ask. So take it away, Dr. Andrews.
Awesome. Thank you for that introduction. So yes, when I was thinking about how to design this talk this time last year, I feel like two extremes of this. If you have the consults that clearly need an ID consult, the Staph aureus bacteremia, the Candida endocarditis, the osteomyelitis, like, okay, the hospitalist, you're going to consult ID. And then you have the other extreme of the, simple cellulitis, that you feel very comfortable managing on your own. But I do think there's this in-between zone of infections that you feel like, oh, I feel like this doesn't really need a full ID consultation, but I also feel like it's a little bit out of my comfort zone. And so that was kind of the impetus for making this talk, to kind of bridge that gap to hopefully increase your confidence and competence in managing those infections. And when I thought of what in 45 minutes we could effectively distill down this gap, the infections that come up the most are gram-negative rods. And so that's ultimately going to be the basis for this talk. So I'm hoping at the end of this talk, we're going to use a case-based format based on a UTI backbone, but it can be applied to all gram-negative rod infections. But specifically, you will be able to classify UTI based on its syndrome. You'll be able to appropriately choose the empiric antibiotic for a serious infection. You'll then be able to interpret susceptibility data confidently to make a final antibiotic choice to then decide a duration. So first, we're going to start with a case. In this case, we'll kind of follow through from the beginning to the end. It'll build on in complexity. So we have a 55-year-old woman who's coming to your emergency room. She has 3 days of worsening dysuria, right flank pain, and fever. She's febrile, she's tachycardic, she has soft blood pressures. She has a leukocytosis to 15. She has a mildly elevated lactate of 2.5. She has pyuria, meaning white blood cells on her urinalysis. She has a CAT scan that shows some right kidney fat stranding, but no abscess. So the emergency room starts her on vancomycin and cefepime, and then admits her to medicine. So my first question, which seems very simple on its face value, and you might have thought that this question was going to ask you what antibiotic to choose, but instead we're actually going to start a few steps behind that. So I want you to classify this patient. I want you to classify this patient as an uncomplicated UTI, a complicated UTI without sepsis, or a complicated UTI with sepsis. Think about that for a second. And the reason I made that the first question and not what antibiotic to pick is because I also still attend on the hospital medicine service and with the residents on general medicine as well. And I feel like this was also my kind of default thinking when I was an intern, but has since evolved. But I feel like a lot of people's default thinking is my patient sick? So do I think they have sepsis or not? And if I think they have sepsis, I have this default regimen that I put all my patients on. So I put them all on vancomycin and piperacillin tazobactam or Zosyn. So vancomycin, or I always put people on vancomycin, or I always put people on vancomycin. It becomes this reflex. And I'm hoping the biggest takeaway you come from this talk is that we stop this kind of linear one process thinking that all patients that you're classifying as sepsis end up on this one regimen, because there will be instances when that's ultimately the incorrect regimen. And so we're going to build a framework that's 5 steps that can allow you to correctly choose a regimen confidently for these infections. And it actually starts a full few steps back, which is what our first question was, and that's classifying the infection. So we're going to use UTI as the prototypical, but you could apply this to any GNR infection, intra-abdominal, et cetera. So we're going to start with UTI, though. Traditionally, I think when a lot of us went through training, this is how it was taught to us. Very narrow definition for an uncomplicated UTI. You had to be a non-pregnant woman, was the only way you could be classified as uncomplicated. You had acute pyelonephritis as a syndrome, and then pretty much everything else was made into this big nebulous bucket of complicated UTI. including all men. So all men by default, the male factor, automatically a complicated UTI. When I think all of us intuitively know that that's not really physiologic, and instead in ID, we really think of it more anatomic. And so this is generally how an ID clinician would classify UTI. The new guidelines, our society, IDSA, is going to be coming out with guidelines hopefully in the next year that will codify this, but clinically, this is how a lot of us are practicing. And instead of using this kind of nebulous framework, instead we say, where is the infection? So if the infection is confined just within the bladder, so cystitis, we call that an uncomplicated UTI. But once the infection moves beyond the bladder, so we have tissue involvement, such as with the kidney, then we call it a complicated UTI. The other thing that's really important in considering something a complicated UTI is fever. So with simple cystitis or an uncomplicated UTI, you should not have fever, right? Because the infection is confined within the lumen of the bladder. The presence of fever, which implies systemic inflammation, by default is telling us there's an element of tissue invasion of this infection, and should always be a red flag when someone's presenting to you, or if you're admitting someone and you're hearing UTI with fever, automatically complicated. The other thing with this symbol is in the upper right denoting is hardware. So if there's hardware involvement, by definition, the infection has left the bladder. So if there's a Foley catheter, if there are stents in place, PCNs, by definition, that'll also be a complicated UTI. So step one of the infection, we're going to classify this with our framework. And so we're using UTI for this, uncomplicated versus complicated, thinking of where is the site of infection. And then the second part that goes along with it, before we think about the antibiotics, is we have to assess the disease severity. And I'm talking to a lot of hospitalists, so y'all are very excellent at dealing with this. This is probably a big bread and butter for you, sepsis. So sepsis, there's all these different calculators, risk models, but the distilled definition of sepsis is you have someone who clearly has an infection, and we're seeing evidence of end organ dysfunction. And so when we're coming back to our patient, we need to classify what this infection is. So we have someone with dysuria, right flank pain and fever. So we think they have an infection, and this seems like a GU infection. So we're going to think about our UTI classifications. We're seeing fever, we're seeing flank pain, and we're seeing kidney fat straining. So that's showing us that there's infection beyond the bladder, there's tissue involvement. So that's a complicated UTI, right? And then we want to assess its severity. So is there or is there not end organ dysfunction present? And so we're seeing someone who's having an elevated lactate, so decreased perfusion of the end organs. We're seeing tachycardia, we're seeing soft blood pressures. So I think we'd all feel pretty confident in saying that this is a complicated UTI with sepsis. Okay, so the case continues. So we have our patient with complicated UTI with sepsis who got vancomycin and cefepime in the emergency room and is now admitted to you, and you're doing their H&P. While you're doing that, the microlab calls you and says this patient has 1 out of 4 bottles growing gram-negative rods. Okay, scary. I thought I'd take a brief aside real quick. I feel like I didn't actually have a great grasp on this actually until I was an ID fellow of what 1 out of 4 or 3 out of 4 or 4 to 4 bottles mean when people are reporting that. So as we know, the standard practice when you're getting blood cultures is typically to get 2 sets from 2 distinct peripheral sites. But actually each set of blood cultures, it's called a set because there's 2 bottles. There is both an aerobic bottle and an anaerobic bottle. While the anaerobic bottle has anaerobic in its name, aerobic bacteria, which is the vast majority of bacteria, still grow in the anaerobic bottle. The thing that makes the anaerobic bottle special is it has a lot of extra nutrients to help those anaerobes, which are often difficult to grow. So you can, with simple E. coli or Staph aureus, you often can still have 4 out of 4 bottles. So if the lab is telling you that 1 out of 4 bottles is positive, that literally means of the 2 sets, 1 of them is positive, which can help you kind of understand the titer of the infection. The more bottles that are positive, the more of a burden of the bacteria that's in the blood. Okay, so we have this complicated UTI with sepsis, and now we're told that there are GNRs growing in the blood. So now the question is, what antibiotic are you going to order? Are you going to do ceftriaxone? Are you going to do cefepime? Are you going to do piperacillin tazobactam or zosyn? Are you going to do meropenem? Or are you going to do ciprofloxacin? Okay. So what I'm hoping is going through your mind, you're like, this is tough. I don't feel like I have enough information to answer this question. You would be right. This is a trick question. There will be cases where all of your favorite go-to empiric regimen are going to be incorrect. There will be cases indeed where Meropenem will not be sufficient for your patient and will be the wrong choice. So right now, you cannot correctly answer this question. So that gets us to how do you correctly answer that question? So we go to our schema. We've classified the infection. We're thinking this is a GU infection. With our GU infection schema, we said this was a complicated GI. We said that they have sepsis. So now we need to make an empiric antibiotic selection, right? This patient is bacteremic, they're unwell. We need an empiric broad spectrum regimen. Okay. These are the three big questions that I want to go through your mind before you make that decision. And often that decision will lead to your favorite antibiotic that you ultimately do, but there will be a few cases, I bet you, if you start implementing this, within the next 2 months, there will be cases where you divert from your kind of go-to regimen. So the first and most basic is you need an antibiotic that treats the typical pathogens for your infection, like obviously. But the second part that sometimes gets overlooked is that antibiotic needs to get to the site of our infection. The prototypical example of this is the CNS, right? I think we all are well aware that certain antibiotics don't penetrate the CNS very well. But there are a lot of antibiotics that actually don't penetrate out of the bladder very well, don't penetrate generally to the tissue. So it's not just CNS infection. We need to generally know that our antibiotic penetrates the tissue where the infection is located. Okay, so we have an antibiotic that works and gets to the site where the infection actually is. The second one is we need to think about, okay, what are the risks of this patient having a multi-drug resistant organism? Prototypic example, Pseudomonas, MRSA, extended spectrum beta lactamases or ESBLs. Besides someone's past history, the biggest risk factors for newly acquiring this is that they've gotten prior broad spectrum IV antibiotics in the last 90 days. So we're thinking, okay, we need an appropriate antibiotic that gets to the site of infection. Has my patient been getting broad spectrum antibiotics in the last 3 months? And then the last but most crucial that I really hope a lot of y'all start implementing after this talk, which some of y'all might already be doing, is looking at the prior culture data. We know in ID that people's floras are pretty stagnant. Things can come and go, but the bacteria that typically are causing their infections in the past are often those same bacteria that we find today. The past predicts the future. Every EMR puts this information in different places. I took a screenshot of what the Brigham's looks like. If you don't know where in your EMR prior culture data is found, please, ask your ID consultants next time you're consulting for something else. Just throw that in at the end of the phone call, because I think you should really know where this is, because I want you to be looking at this every time you're seeing a sick patient. So you're going to find that location, wherever that is in your EMR, and you're going to go to the site of infection that you're currently treating, right? We want to do things within reason. If you're worried someone has a UTI, the sputum culture that grew, Corynebacterium 10 years ago, that's irrelevant. So we're going to look in cultures within the last year that are relevant to our infection. So for us, we're looking in the urine. And the biggest thing I want you to take away when you're interpreting these susceptibility tables, when you're looking at a gram-negative rod, the very first antibiotic that your eyes should always go to is ceftriaxone. No matter what, even if you weren't going to start ceftriaxone, that is the antibiotic we want to be looking at to see what the resistance is. And we're seeing that this E. coli that has grown in the past for this patient is resistant to ceftriaxone. And the reason that's so important is the dreaded, ESBL, the alphabet soups, resistant patterns of ID. I don't want to lose anyone. I promise we'll keep this relevant. But what is ESBL, and why is this important to you as a hospitalist? So this is it stands for extended spectrum beta lactamase. This is actually a family of resistance genes for gram-negative rods, or Enterobacterialis as we call them. And what these enzymes do is they hydrolyze or inactivate many of our even broad-spectrum agents. So even up to our third-generation cephalosporins, our beta-lactams, hydrolyzes them, makes them inactive, okay? This is becoming a bigger problem even in community settings that typically weren't seeing this in the past. This was often something more prevalent in South Asia in particular, but we're seeing this a lot in our settings now. And when we're trying to find if something is an ESBL, technically this is a gene that's causing this, but obviously it's not feasible to sequence, all isolates to see if they had these genes, right? There's many different genes. And so instead what we do is we say, if this patient has ceftriaxone resistance, clinically, we're going to call them an ESBL. The one exception is that some centers do these PCR tests. So when a blood culture incubator alarms off as positive, the microtech will do a quick gram stain. And then based on the gram stain, they might send a PCR panel. A lot of places do this. They might do a gram-positive panel or the gram-negative panel. And within these panels, it'll identify, the bacteria based on DNA, but then it also has some resistance genes it'll look at. So this one is ephesium, and it's showing you that they have a certain vancomycin resistance gene. So some places will give this information, but I would say this isn't necessarily common. And even if it doesn't identify the gene, always know it's only usually looking for one gene. And remember, this is a family of genes, so you shouldn't be reassured necessarily if it doesn't identify something as ESBL on the PCR. Okay, so the big thing just to take away, when we think about ESBL, all that means is we have a GNR, a gram-negative rod with ceftriaxone resistance. The second and last main point about ESBL phenotype is knowing that this is not a virulence mechanism. I find a lot of people get very nervous and anxious about ESBL and associate it with a more severe infection, but that's not the case. ESBL is just a resistance mechanism. So that ESBL E. coli is just as virulent as that pan-susceptible E. coli. Both can cause someone to be in septic shock in the ICU, and both can cause simple cystitis in the 80-year-old woman who just needs, 3 days of antibiotics. So it's a resistance mechanism and not a virulence mechanism. Okay. I wanted to point you to a resource that I think is really helpful to help bridge this gap, especially if you, after this talk, it's a few weeks down the road and you want to kind of remember what we talked about. So the IDSA, which is our professional society, put really great guidelines last year on these infections. And the audience for these guidelines actually isn't ID clinicians. It really is directed towards hospital medicine and general internists. And so this is a resource you can use to also, when you don't have ID to consult, that you can turn to answer your questions confidently. Okay. So thinking about ESBL, so we've clinically defined it as a gram-negative rod with ceftriaxone resistance. So why is it so important to first look at that ceftriaxone? Because that then informs your next choices. So if something is identified as an ESBL and their prior history, and someone's sick in front of you with sepsis, so they have a severe infection, you actually really do have to use a carbapenem. Even cefepime, piperacillin tazobactam, even if it says susceptible, we've had data showing that they have worse outcomes. So these patients do need to be on meropenem or ertapenem. Okay, that's severe infection though. So I also now want to take away out of our brains that ESBL E. coli always equals 14 days of ertapenem. That's only severe infections where we're starting out. Besides that, remembering ESBL is only a beta-lactam resistance gene. So all your other antibiotics like Bactrim, fluoroquinolones, nitrofurantoin, fosfomycin, that aren't beta-lactams, this has no influence on them. And so if they're susceptible, go for it. They work. And so this is why we had to classify the infection. So when we said something was complicated UTI or uncomplicated UTI, because we needed to know if there was tissue involvement. And why is that important? And that's because Bactrim or trimethoprim, sulfamethoxazole, and our fluoroquinolones, ciprofloxacin, levofloxacin, moxifloxacin, they get great tissue levels. So they're very good when the urine infection is penetrating. However, if it's an uncomplicated UTI, where it's just simple cystitis, you don't necessarily need that. You can, still use that, but you can also use antibiotics that just concentrate in the bladder, like nitrofurantoin or fosfomycin. So yes, even the big scary ESBL E. coli, when it's growing on urine culture, if it's simple cystitis, uncomplicated UTI, and it's nitrofurantoin susceptible, please send them out on nitrofurantoin 5 days, okay? The big point from here, though, is nitrofurantoin and fosfomycin cannot be used if it's a complicated UTI, right? These are not penetrating the tissue. And so when we're having infection leaving beyond the bladder, we cannot use these agents, even if it's reporting susceptible, because it's not at the site of infection. One little thing, little pearl, just to put in your background, for some cases is this alternative single dose aminoglycoside. I think a lot of people don't have a lot of comfort using aminoglycosides anymore, used all the time 20 years ago, but a lot of newer agents have come out. But I think there can actually still be a great role here for these agents. So what are our aminoglycosides? These are like gentamicin and amikacin. And the way aminoglycosides work, how their killing power work, is what we call peak-dependent killing. And so all that means is getting a really high dose of aminoglycoside is what determines its efficacy against the bacteria. And so that's really appealing because we can give one-time really high dose that gets it to a really high level that then can effectively treat uncomplicated infections. And so it is actually guideline recommended as an alternative if someone can't go out on a PO regimen. Absolutely, if someone has an uncomplicated UTI, a one-time dose of gentamicin and they're done, and that'll effectively treat them. And so I frequently use these in our patients who get curbsided or consulted in the emergency room who have an ESBL, E. coli, cystitis, and unfortunately they can't take PO or all the POs are resistant. But I obviously don't want to send someone out with a PICC line for just 5 days of antibiotics. This can be a great option for these patients who need to be discharged, single dose aminoglycoside. Okay, there's controversy over cefepime and piperacillin tazobactam with ESBL. You shouldn't use this empirically. These patients should be on carbapenems when they're sick, and then you de-escalate. And then if they're not sick, we shouldn't be using beta-lactams at all. We should be using non-beta-lactams. But often what ends up happening is people were on piperacillin tazobactam or they were on cefepime, and then the culture comes back and it's ESBL, but the patient's getting better. What do you do? So this is something where it is sometimes worth talking it over with pharmacy or with IT. And then the last, I promise this is the last alphabet soup of the talk, but whenever you talk about ESBL, you can't not talk about AMP-C. And so I just wanted to make sure we contrasted the two because this also can come up in your empiric antibiotic choices. So we said ESBL is ceftriaxone resistance with GNRs, resistance pattern. Patients should be on carbapenems for severe infections, non-severe infections, a non-beta-lactam antibiotic, or can be used in step down. What is AMP-C? So AMP-C, the AMP stands for ampicillin. AMP-C is a beta-lactamase, but it's not constitutively active. And what does that mean? It's inducible. So it's not always active. Sometimes it's quiet or sleeping. We know there used to be all these acronyms people would throw out, SPICE, SPACE, to kind of remember which bacteria do this. But we've learned that there really are 3 that are most important. And it's Enterobacter cloacae, Klebsiella aerogenes, noting this isn't Klebsiella pneumoniae, it's a very distinct species, Klebsiella aerogenes, and Citrobacter farumii. And this is a chromosomally mediated process typically. So most of these species are going to have this present. And so it's defined by the species, by its phenotype. So what does this mean, breaking it down graphically? So ESBL, this little diagram, we have this Petri dish to represent in vitro, so the data that the lab is reporting, and then I have this human body reporting what's actually happening in vivo in the patient. And what's reported in your lab results is the same thing that happens in the patient. So we have our E. coli here, let's say, and the E. coli is an ESBL E. coli, okay? So it's ceftriaxone resistant, it's making this beta-lactamase. So it does that constitutively, meaning continuously it's secreting beta-lactamase, which is what these enzymes are. And so if we give this patient antibiotics, which are these pills, the beta-lactamases are already there, and they're going to chew up the antibiotics, which is bad news for our patient, right? Patient dies because the antibiotic is gone, the infection progresses. So the same thing we're seeing in the Petri dish is the same thing that happens in the patient because that enzyme is constantly being made, and so it's going to chew up any of those early generation beta-lactams it gets. AMP-C, unfortunately, is different. So same thing in vitro and in vivo, left and right. In vitro, when the bacteria sees the antibiotic, the early generation beta-lactam, it actually works. It's effective because this just gets incubated for 1 day and gets shown, okay, it's effective, and gets reported as susceptible. But unfortunately, what happens if it's a bacteria that has this AMP-C gene, and this is an inducible gene, so what does that mean? After 3 or 4 days of the bacteria being exposed to these early generation beta-lactams, this causes upregulation of this AMP-C gene to where now it's churning out tons of these beta lactamases. And so while in the lab, which only held the specimen for a day, and the gene wasn't yet active, so it didn't have the beta lactamase, so it's read as susceptible, great, which is what your report's going to say. But in 4 days inside the actual patient, this gene is all of a sudden be rip roaring 100 miles per hour, churning out this beta lactamase and now chewing up all that ceftriaxone, and the patient's going to have a secondary worsening. And so you're like, oh my gosh, so I have to memorize all this stuff in addition to my cardiology and pulmonary. They'll have so many things you have to do. What I'll say is a lot of labs are recognizing that's hard to remember, especially in someone who's not in ID. And so there was a big QI project at Mass General and the Brigham, and a lot of other institutions are doing this to flag it for our clinicians. And so what you'll see is we have a bacteria here, Klebsiella aerogenes, which was one of those 3 that does have AMP-C phenotype. And what you'll see is ceftriaxone, it says susceptible, which it almost always reports as susceptible, right? Because the gene is quiet, those first few days. But there's this little asterisk by it, and it shows exactly what I was telling you there. This organism, when treated with ceftriaxone, even when it's susceptible, often has failure. Consider an alternative therapy if more than 4 days of treatment is anticipated. And so if your lab doesn't do this, I think this would be a great QI project or something to kind of flag for them. I think it's generally easy to implement, and I think it can help prevent us from having to remember when you have many other things to do. So our summary slide of kind of the 2 resistance mechanisms I think are really important to know as a hospitalist because it informs your antibiotic choices are ESBL and AMP-C. So we were finishing up with AMP-C. There's 3 bacteria, Enterobacter cloacae, Klebsiella aerogenes, Citrobacter fruendii, inducible resistance. So it's just no matter what, with these bacteria, we see it. So even though that the report's going to say it's ceftriaxone susceptible, we know in vivo inside the patient in 5 days' time that ceftriaxone is going to be chewed up by all this induced beta lactamase, and so we can't use it. Luckily, we have a lot of great trials that high-dose cefepime actually is effective for these infections. So cefepime at the 2Q8, 2 grams IV Q8 dosing, if the MIC is low, is the preferred regimen, but you can also use a carbapenem. And then same as ESBL though, this is a beta lactamase. So all your other normal, fluoroquinolone, Bactrums, your non-beta lactams treat just like normal, okay? So AMP-C, inducible resistance, ESBL, it's always on, and it's, based on ceftriaxone resistance. Back to our case now. Okay, so we had our complicated UTI with sepsis. You're admitting the patient. You're told that they have 1 out of 4 bottles with gram-negative rods. So we think through our step 3, right? We classified the patient, and now we're ready to the severity, and we're ready to make our empiric choice. So we thought about, okay, we need to cover our gram-negative rods. So the type of bacteria we're covering, we need to make sure it's penetrating to tissue because we have bacteremia and pyelonephritis. We've assessed their MDR risk factor, looked at their prior cultures. And so when we looked at their prior cultures, we saw that ESBL E. coli, because we looked at the ceftriaxone, it was resistant. So even if your lab doesn't label it as ESBL, it's ESBL E. coli. She had that 6 months ago. So now in our patient with a complicated UTI with sepsis, with an ESBL E. coli in her urine 6 months ago, what antibiotic would you order? Would you do ceftriaxone? Would you do cefepime? Would you do piperacillin, tazobactam? Would you do Meropenem, or would you do ciprofloxacin? So yes, you would want to do Meropenem. So remember, with ESBL, we really need to be using our carbapenems. We don't have great data showing that cefepime is non-inferior to carbapenems for these infections. For AMP-C infections, so if I had changed this, same problem, but instead of ESBL E. coli 6 months ago, she grew Enterobacter 6 months ago, so no ESBL history. Cefepime absolutely would be adequate here. Okay, so the case continues. So she grew that ESBL E. coli 6 months ago. We have the 1 out of 4 bottles with GNRs, and so you started her on IV Meropenem. On hospital day 2, she's improving. So her back to her baseline, her dysuria and flank pain are gone, the fevers are gone. Both the blood and urine cultures are now speciated with E. coli, and have this susceptibility profile. Okay? So now I want you to think about patients been on Meropenem. We're getting better now. And so what antibiotic are we going to rotate, quote unquote, narrow or complete the course with? Are we going to put in a PICC line and send them out with ertapenem? Are we going to do a PICC line with cefepime? Are we going to do trimethoprim sulfamethoxazole? Are we going to do, or Bactrim? Are we going to do amoxicillin clavulanate or augmentin or ciprofloxacin? So remember, classify the patient. Where are we at? We're now ready to make an informed choice. So we're going to look at our susceptibility. Remember, it's a GNR. So we're going to always look at one antibiotic first, even if that antibiotic isn't a choice. And then we're going to think about, okay, what can we do next? Okay. So that gives us a set form. And so this is making that culture-directed antibiotic choice. And so when you're doing this, there are 4 big questions I want you to go through in your brain. 1, the patient better be improving on the empiric therapy you chose, right? If they're not improving, we need to rethink if we have the right syndrome. They might have some other problem going on. Number 2, we want to make sure we have source control before we're kind of finalizing someone's antibiotic plan. So if they had a big bad abscess, we want to make sure that got drained before we're kind of messing with their antibiotics. 3rd, absolutely, we want a susceptible antibiotic, but same thing, just like with empiric antibiotics, it has to be susceptible, but also get to a therapeutic level at the space of infection. So prototypic with our UTIs is even though nitrofurantoin or fosfomycin might get reported susceptible, it will not penetrate tissue well. And so, it shouldn't be used outside of simple cystitis. And then the last one that I think it's under thought about a lot is we really need to be favoring oral antibiotics way more than IV antibiotics. Whenever I say this, it blows people's minds sometimes because I think we have this false equivalence in our brain that IV is better than PO. Patients often feel this too. But there's actually not a single trial that has shown that IV antibiotics are better than oral antibiotics. Not a single trial. It's like mind-blowing. And yet we have this thought in our head that IV is always better. And there's a lot of complications with IV antibiotics. If you do OPAC clinics or, see people long-term, you'll see they will get those DVTs. They will get those phlebitis. They will get those catheter-associated infections. And it's just very expensive to do outpatient IV antibiotics or put people in SNFs, skilled nursing facilities for 4 weeks. And so if you have an effective, highly bioavailable oral antibiotic, we should always and it can be absorbed from the patient, you don't have concerns about that, we should generally be favoring our oral antibiotics. Okay. So when I'm thinking now about this patient, back to our question, so she had this complicated UTI with E. coli bacteremia on meropenem because of her prior history of ESBL. She's now improved, so clinically improving. We think we have source control. So we now need to choose a susceptible antibiotic in the right level, and we're going to generally favor PO antibiotics. So when we apply that, we say, okay, it's E. coli, so it's a gram-negative rod. So I always look at ceftriaxone resistant. So it confirmed the past predicted the future. So she has an ESBL E. coli isolate. So we're not going to want to be using our beta-lactam PO option. So you wouldn't want to be using augmentin here. So we're going to want to look at our highly bioavailable agents. Okay, so we want that. And number 2, we have to think about where the site of infection was. So this was a tissue invasive infection, a complicated UTI, bacteremia. So we're not going to be using our nitrofurantoins, right? We need to be using our fluoroquinolones or trimethoprim sulfamethoxazole. Unfortunately, her ciprofloxacin and levofloxacin are resistant, but luckily, trimethoprim sulfamethoxazole, highly susceptible. So absolutely, this is a patient who really should be going out on Bactrim. There are some cases, creatinine issues, other reasons where you might, have to put someone on a PICC line and ertapenem. But generally, if we can, let's use our oral antibiotics. Okay, the case continues. So our complicated UTI with sepsis, who was on meropenem, got better. The blood cultures ended up showing ESBL E. coli. It's now hospital day 2. You rotate her down to her trimethoprim sulfamethoxazole. So you're ready to discharge the patient. So you're completing her discharge. What duration of total antibiotics, inclusive of the time that she spent on IV, are you going to dispense? Are you going to say that they do 5 days of total antibiotics, 7 days, 10 days, or 14 days? So complicated UTI with sepsis, with bacteremia, ESBL, E. coli. Think what you would actually do today if you were discharging this patient. It's like a smattering of results favoring kind of the 7 to 10 day range. So that gets to our final part of how I think about gram-negative rod infection. So we classified the infection. For UTIs, we're thinking about anatomic site. Is there tissue invasion or not? Uncomplicated or complicated? We assess the severity. Is there sepsis? So is there end organ dysfunction with the infection? We had to make that empiric antibiotic choice, which we used our prior cultures and MDR risk factors to inform us in making sure that that antibiotic got to the site of infection. We then were doing better, and so we're ready to de-escalate to a culture-directed antibiotic that we highly favored PO antibiotics when able, and one that also still gets to the site of infection. And so now we have to think about how do we decide about the duration. Luckily, in the UTI space, there's a lot of data to inform this. So I just picked one. This was retrospective data published in our main specialties journal last year. So who were these patients? These were adult patients who had gram-negative rod bacteremia across a multi-center hospital group, and they had to be considered a complicated UTI. So they needed to grow the same bacteria in the urine as in the bloodstream to suggest that that was the source, okay? And they looked at patients who received 7 days of antibiotics, combination of IV and oral, 10 days, or 14 days. Complicated UTI, so remember the definition, you have to kind of be very stringent in how you apply it. And they considered male sex a definition of complicated UTI, but we know now male sex does not necessarily mean complicated UTI. But in this trial, that's what they did. So what did it show? No difference. So 7 days on an IV beta-lactam, we're treating with a highly bioavailable tissue-penetrating agent, trimethoprim sulfamethoxazole, fluoroquinolone for these patients with a UTI, complicated UTI with bacteremia. No difference in 7 days versus 10 days for risk of recurrence. So I think this is generally starting to penetrate through down, definitely to the hospital medicine groups. I think a lot of people are feeling more comfortable with this. I feel very comfortable in this case having this person on 7 days of antibiotics. She quickly improved. I don't think 10 days is wrong though. If maybe it took 3 days, it was a bit slower, it wasn't a rapid clinical improvement, and you feel like, okay, we need a few extra days, I think that's fine. I do think most patients really don't need 14 days anymore. I think 5 days might be a little short. So I think in that 7 to 10 day range is a good thing to shoot for. And so that's our schema. So we classified the UTI, and hopefully you're kind of seeing why that seems like a kind of an obvious but simple question. Actually, it can be a little complicated, and it actually really informs every other decision you make. So you have to start there, classifying it, the severity, make your choice, narrow down, and then decide your duration. So I said complicated UTI, we're going to talk about uncomplicated. Uncomplicated UTIs, it depends on the agent you use, like nitrofurantoin, it's 5 days, trimethoprim sulfamethoxazole, it's 3 days. Remember that one time aminoglycoside dose, it's just 1 day, so that varies somewhat. I wanted to hone in on 2 separate points that we've kind of talked about, but just to kind of increase your confidence in this. So we're going to think more about the male factor. So we have a 55-year-old man. He has 3 days of dysuria. He sees his PCP. He has a urinalysis showing a 3+ esgesterase. He has pyuria. So the PCP empirically starts to give us perfloxacin, which is not unreasonable. 2 days later, this urine culture returns, and the PCP gets very nervous and refers the patient for the emergency room to get a PICC line placed and 14 days of IV antibiotics. And this is not an uncommon situation we see. So the ED starts Meropenem and admits them to your service. So what antibiotic would you use? Would you use nitrofurantoin for 5 days? Would you use the ertapenem for 14 days? Would you do ertapenem for 7 days? Would you use gentamicin times 1 dose? So think through our whole process. So really think through it. Classify this infection. What is the severity? We have to make a culture-directed choice. So we need an antibiotic that's susceptible and is at the site of where our infection is, favoring oral over IV when we can, and then the duration, 3 to 5 days for uncomplicated, 7 to 10 days for complicated. Okay. So remember, why it's so important to classify infections is because it determines everything else. So where is this infection? Is it just in the bladder, so it's an uncomplicated UTI, or is it moved beyond the bladder? Sex does not factor into our decision-making. It's, do we have tissue invasion or not? So when we have a man who's just having dysuria, we're not having any fever, we're not having any chronicity to think this is like a prostatitis or some, obscure problem. We have no flank pain. So really this seems like just in the bladder. So it's an uncomplicated UTI. And so why did our thinking change on this? I just wanted to show one piece of data, because I think a lot of people maybe did, grow up in the era where male factor was automatically complicated. So this is a really sentinel trial that was published in JAMA 3 years ago. There are some criticisms of this trial. You can see a lot of people get excluded from it, but it's still, it's an RCT that's placebo controlled. So these were men who had a symptomatic, uncomplicated UTI, couldn't have been, had to have susceptibility data, and it had to be susceptible to Bactrim, trimethoprim, sulfamethoxazole, or ciprofloxacin. So these patients were randomized to either 7 days of antibiotics or 14 days. The people that were in the 7-day arm still got 14 days of pills, just the remaining 7 days were placebo. Showed no difference between the 7-day and the 14-day arm, which really started, really showing us that male factor alone does not necessarily make something complicated. This is just one piece of data to help inform that. So looking at our patient, so we already classified this as an uncomplicated UTI. There's no sepsis physiology. Someone already made an empiric regimen, so we're ready to do a culture-directed one. So, right, we see it's a gram-negative rod. So the first antibiotic we always looked at, right, ceftriaxone. And we saw it was resistant. So this is what the ESBL, extended spectrum beta lactamase, E. coli, which isn't scary. We're no longer scared of it, right, because it's a resistance mechanism. It's not a virulence mechanism. This could be a pan-susceptible E. coli. It's the same severity of illness, okay? But we do now know it's an ESBL, so we don't want to be using beta-lactams, oral beta-lactams for this patient. But it's an uncomplicated UTI. So all we need is an antibiotic that gets really high concentration of the bladder for 3 to 5 days of duration. And so we want to look at our orals, right? Because we always favor orals. We see, okay, trimethoprim, sulfamethoxazole is susceptible. That would be a perfectly acceptable answer. Fluoroquinolones, it's resistant. And typically we only kind of want to save our fluoroquinolones if there's tissue invasion. But looky here, nitrofurantoin, susceptible. Yes, ESBL E. coli, uncomplicated cystitis. Please use nitrofurantoin. Would be a great option here. 5 days of duration. This patient did not need to be admitted to the hospital, sent to the ED. And I think it's actually would be doing harm to the patient, putting that IV as long as they can take oral antibiotics. I just highlighted gentamicin here just to remind myself it's actually resistant to gentamicin, so you wouldn't want to use it, but just always keeping that in the back of your head. Maybe the PCP sent this patient to be admitted because they have really bad allergy to Bactrim and for whatever reason also can't take nitrofurantoin. Still doesn't mean they necessarily need IV antibiotics. You can always use that one-time dose of aminoglycoside if it's susceptible. It's actually resistant to gentamicin, but it's susceptible to amikacin, which is another aminoglycoside. So you could use that to save the patient from needing to pick one. My last slide before the review is just reminding us about catheters. So I think this gives us all a lot of angst, in the hospitalists and the ID clinicians alike, what to do with these chronic Foleys, these chronic suprapubic tubes. The grandma who's at the rehab who is acting a little different today versus yesterday. So someone says, let's check a UA. It's of course positive on the Foley, and of course grows a million bacteria or even, Candida. What to do with it? So really think, do you really think this patient has a UTI when someone has a culture that's sent off of Foley? Always remembering that a positive urine culture does not equal infection. It can be really hard, though, to differentiate this in these patients. So do your best. Is there a leukocytosis? Is there a fever? We're seeing evidence of systemic inflammation where, yes, definitely, of course, there's an infection. If it's just mental status change, maybe we just exchange the Foley and watch them for day or two and see like, oh, actually, this is just waxing and waning delirium before we just empirically give these patients, days and days of antibiotics. But if you decide to treat, you should always remove the Foley, right? Well, why is that? We know these Foleys within 5 days get coated in something called biofilm, which is just thick crud of slime where bacteria and fungi just love to insert themselves, and they become inert during it. And so they don't get killed by antibiotics. And so then when the antibiotics stop, though, the bacteria slowly elutes back out into the bladder and causes recurrence of the infection. So you should always be exchanging these no matter what, suprapubic tubes, PCNs, Foleys. Whenever you're concerned of infection, they always need to be exchanged when you're starting antibiotics. There's data behind that. And duration, remember, catheter by definition is complicated. These don't need super long courses, though, 7 to 10 days, just like any other complicated UTI. So my big take-homes from the talk, I'm hoping you feel more empowered about your empiric antibiotic decisions related to gram-negative rods, that really we need to be classifying our syndromes before we just default to our favorite antibiotic, thinking about where the site of the infection is, what type of bacteria caused that syndrome, what the severity of the illness is. And we always look at their prior cultures because the past predicts the future. And there are times when meropenem, when cefepime, when ceftriaxone, piperacillin tazobactam will not be appropriate for that patient. So please find where that is wherever you practice. I hope you feel more empowered about ESBL, that it's not a virulence factor. It's not something to be afraid of or something that needs necessarily even that needs ID consultation. This is just as severe as an infection as a pan-susceptible E. coli. It's defined by ceftriaxone resistance. You shouldn't be using carbapenems if it's a severe infection, but please, use those non-beta-lactam antibiotics otherwise with the same durations as otherwise indicated. Remembering that male factor alone does not make something a complicated UTI. And then having a gram-negative rod bacteremia does not typically alter our treatment durations or preclude the use of oral antibiotics. So thank you. Happy to take any questions.
Thank you so much, Dr. Andrews. We really appreciate the jolt of high energy to finish the day here. Just to recruit, so the male factor is then simple, is that right?
Yes, the male factor is uncomplicated. It's not, excellent. We don't consider the male factor in our decision making, excluding prostatitis. So remembering prostatitis is a whole different beast.
Yep. So just getting back to what you were trying to slide in there at the end of the talk, so there were a lot of questions that were some variation on how do I know whether this patient has a UTI or not. So, Mrs. Murphy rolls in and she's a little off her feed and she's a little dry and she's got 25 white cells in her urine and she grows 25 to 50,000 colonies of E. coli. So first of all, is there anything in particular in the UA, any particular values that if you're kind of on the fence about treating, a threshold for, white cells, pyuria that would tip you over into treating?
Yep.
Or anything else from the UA? Yeah,
so that's a very good question. It kind of goes along with this, that pyuria alone does not also indicate UTI has very low specificity for UTI. And so our kind of what we typically quote to people is there's data behind this that if someone does not have pyuria, though, so if there's less than 10 whites for sure, but I would even increase that up to 20, less than 10 to 20 whites, white blood cells per high-powered field, the patient does not have a UTI, right? To have a urinary tract infection, there has to be inflammation present. And so if someone has less than 10 to 20 whites, you can feel confident that that's very high, over 90% negative predictive value against the presence of a UTI, no matter what the culture ends up growing. So that's number one. That's really helpful. There's no pyuria. The hard part is when there is pyuria, the 50 to 100 or even over 100 WBCs, the urine culture is positive. You have to use the syndrome in front of you. Unfortunately, we're not going to go biopsying the bladder or, doing a PET CT of the bladder. There's no great test to give you. You have to use the syndrome in front of you. So do they have clinical symptoms of a UTI? Yes, treat. If they don't, I would not treat. I always, the altered mental status, I don't typically think of as a symptom of a UTI. It needs to be part of a bigger syndrome before I'm going to say just the delirium is what caused, the UTI caused delirium.
Yeah.
I wish it was easier.
Yeah, no, I know it's really hard. I often think about this a lot, honestly, in terms of how could we get evidence to show whether the delirium is part of UTI, and because it's such a dogma and I'm skeptical of it, but I also don't know how to disprove it either. So we had a lot of great questions, so maybe I'll run over a little bit here. Just getting back to the male factor thing, I come from the era when the dogma was if you had, male UTI, you should treat for prostatitis. If you could comment on that.
Yes, so we definitely don't need to be doing that. You should be thinking, I could have included this, when you do have a man with UTI, in the background of your brain, you should always be thinking, does this patient have prostatitis? And so what are signs of someone having prostatitis? So prostate, so that's tissue. So there should be evidence of tissue invasion. And so what could that be? These patients are typically, if it's acute prostatitis, these patients are typically very sick. Bacteremia is not uncommon with acute bacterial prostatitis. These patients often have a lot of deep pelvic pain. It's a very painful process. They typically have high fevers. So acute bacterial prostatitis, almost no one misses that. It's those chronic prostatitis. And so who are these patients? These are patients who you should, generally this first time when they're coming in, you should not be treating them for more than 7 days of antibiotics, right? It's after you do that, they come back again a month later with the same symptoms. So someone who has recurrently positive urine cultures and symptoms in a man within a short duration, that shows us that maybe we're having a source control problem. And that's when I start to think about they have chronic prostatitis. And so that's when I'm, doing the DRE, very low sensitivity, by the way. So I'm typically sending these people for either a CT, but MRI actually is the highest sensitivity. So often sending these people for an MRI of their pelvis with a prostate protocol if I'm not confident and don't want to empirically treat them. And then yes, you typically treat these for 4 to 6 weeks of antibiotics. But that first go around, if we're not having it, if it seems like an uncomplicated UTI, really please treat it like an uncomplicated UTI.
All right, awesome. You had a question about single dose ceftriaxone for UTI. And also some of the old timers on the group chat were talking about single dose aminoglycosides. If you could comment on that.
The single dose ceftriaxone I would not recommend that. It has to be followed by something else. So that gets to the mechanism of antibiotics. So beta lactams, the way they work is what we call time above MIC, which is why they have to be dosed so frequently, right? Why penicillin is every 4 hours. And so that one-time dose of ceftriaxone, the therapeutic efficacy of it's going to drop very rapidly. So you can give a one-time dose if you want, but that needs to be followed by an oral antibiotic to finish out the course. Why you can do the one-time dose of aminoglycoside is because instead of that time above MIC where we need constant levels, it's peak-dependent killing. So it's getting that level really high is what determines its therapeutic efficacy. So that's why you can, for uncomplicated UTIs, you can give a one-time dose of aminoglycoside, gentamicin preferred more than amikacin, and that can be effective. But a single dose ceftriaxone followed by nothing else would not be effective.
Great. And one last question. So patient comes in, think maybe the patient has a UTI, give some antibiotics, some fluids, patient gets better, and then the culture comes back and it's an ESBL that you didn't treat for. What do?
Yeah. So we don't get this in uncommonly, actually. And which shows, sometimes the dogma we teach, sometimes, patients don't follow it. These patients might do fine on ceftriaxone or cefepime. So if, someone has no prior history of it, and so you appropriately just did ceftriaxone, let's say, and yes, the culture comes back with ESBL. If the patient is clinically improved, at that point, I'm kind of ready typically to transition them to the oral anyway. So I'm kind of getting off the ceftriaxone and putting them on a fluoroquinolone, or I'm putting them on Bactrim anyway. So that kind of makes it easy. If someone needs like another day or two and they really have clinically improved so much, the fever is gone, the blood culture is clear, the leukocytosis is resolving, I do think it's fine to continue it for another day or two to then transition them to their ultimate regimen. Empirically, we shouldn't be starting them if we know it's ESBL, but if someone has improved and you're about to finish up a course, no, I would not just all of a sudden transition them, escalate to a carbapenem when someone's clinically improving.
Great. Awesome. Hayden, thank you so much for a fantastic talk. Great addition to the course.